I've got discussion outline. That's kind of a big word for a 4-minute presentation here, but briefly what I want to tell you is who we are at Kaiser Permanente, and that'll help, I think, give some context for my remarks during our fireside discussion. Who influences the discussions of value at Kaiser Permanente? And as you'll see, we begin with our patients and our members, but it's actually a long and varied list. And then how we approach the value question in practice. And you know what? These actually do not look quite like the slides that I uploaded this morning, but we'll see if this works out. Okay. Very briefly, Kaiser Permanente by the numbers. We're a complete healthcare delivery system operating 37 hospitals with 17,000 physicians taking care of 9 million people across the country in the U.S., predominantly in California, but up and down the West Coast, as well as Washington, D.C. and Atlanta, Georgia. We are about the size of a small Scandinavian, or maybe a large Scandinavian country, and with the exception of some quaternary care, we provide everything in-house: hospital, physician, outpatient, pharmacy, lab, imaging, the works. And this is a bit of an ugly slide, but it's important for you to understand that we're, although I'm here notionally representing the United States, in fact, our model is something the reverse of many of the models in the United States. We begin with our health plan members on, let's see if I can get this to liven up. All of our revenue comes through from our members, either purchasing insurance with us as individuals or coming to us and having being sponsored by their employer or by a government program. So at the beginning of the day, we are prospectively paid for all the care that we deliver. On the expense side, Kaiser Foundation Health Plan provides an operating budget to our hospitals and negotiates what we call medical service agreements, essentially capitation to our medical groups. So we have essentially reverse economics compared particularly with the rest of the United States. Our care delivery side is on the expense side. We don't make money at that. We bring in revenue. We have what's essentially a fixed global budget for the year, and we make do with that to provide all the acute care needs of our members. This forces an alignment that is it's certainly relatively unique in the United States, possibly unique in the world, where all of the stakeholders inside the care delivery system are moving in the same direction. So who influences the value discussion at Kaiser Permanente? I'm using I say customers here, and not to put that in a demeaning way, but we operate in a mixed environment. We are competing in private health insurance markets to attract people, and we are competing in newly formed public health insurance markets beginning January 1, 2014, as well as our public programs that we deal with. All of the members of Kaiser Permanente come to us voluntarily. We need to attract them, so I'm using customers in that sense. And again, as I said, they may come to us individually, they may come to us through their employer, through their labor union, or they may come to us through a public program. We operate in a highly complicated environment. Again, on the health plan side, we, in every one of our markets, have 5 to 10 competitors. We're nonprofit. Most of them are for-profit, investor-owned. We operated in a highly regulated space. We are regulated by the federal governments, the state governments, the county governments. I would include in that private regulations from the accrediting agencies and others, so we are responsive to all of those. At some level, you need to be responsive to the politics of healthcare in the U.S. About half of our total healthcare spend now runs through the federal and state and local governments, and so one needs to be responsive to that. And then, of course, the press keeps an eye on everything, the fourth estate, and it's very easy, particularly around new technologies and rare diseases and other sort of outside the ordinary treatments, to get caught up in very visible discussions in the press. And I know folks from the UK are very familiar with this kind of discussion. We're not quite as brutal, but we get there anyways. And then last but not least, we have ourselves, both care delivery, doctors, nurses, other clinicians taking care of patients have views on value. The health plan has views on value, whether it's around what we need to do in terms of marketing, compliance, government relations, obviously financing and pricing and capital investment are important. We're also very big on environmental stewardship. So we're balancing a lot of different pieces here. And I apologize for the cheesy slide, but I just wanted to make the point that, you know, it is not just providers thinking about value in HTAi. It is not just us looking at our members and asking them what they want. We have a lot of the pieces to contend with. So how do we begin to think about this? Well, I, of course, have a much more primitive set of chevrons here to describe the process than were put up yesterday. But first of all, there's, you know, we need to initiate the question. That may come from customer demand in the United States. There's a lot of marketing, whether it's pharmaceuticals, new devices, new treatments. I can't drive to work a single day without hearing ads for bariatric surgery. So patients and members come into our offices, they want to know about something. That can initiate an HTAi for us. Our clinician, whether they're at a professional society meeting or learning of a new treatment, can do it. The environment, our competitors may offer something. We may have benefit mandates coming from the federal or state government. I won't belabor the point. We do the assessments and synthesis much as many other organizations do. We draw a lot on external HTAi entities. We do some of it in-house. We have both on the device side and on the drug side substantial, I'll call it intellectual infrastructure to look at all the questions broached by new technologies. We have something with the horrendous name of the Interregional New Technologies Committee that actually brings together clinicians, biomedical engineers, ethicists, all of the people you would want sort of thinking about a question. Are we going to do this? Are we going to offer it? For what patient population and so on. Then there's action, and we can have a conversation about this, but I think we're not completely different than many other organizations. You sort of have three choices. You can adopt with some kind of conditions, or you can reject, and that's going to depend on a multiplicity of factors, both in terms of what alternative treatments are available, how strong the evidence is, how prevalent and how burdensome the condition being addressed is. And then we get to being able to monitor it, whether it's through our registries, whether it's tracking new technologies in the literature, whether it's our own clinician reports. All of this for us is not quite a short, I'll use the acronym PDSA cycle. It's not that fast, but it is more or less a closed loop. We do a lot of horizon scanning around new technologies. We know what's coming down the pipeline 3 and 5 and 7 years out. So we're thinking about it early on. We're assessing things as they evolve in their development, and then we're of course assessing them for their effectiveness in practice, not just what we got from the clinical trials and not just what we got from the studies. And I'll stop there. I'm not sure where I am in my 4 minutes, but I'm probably pretty close. But to say that, you know, we operate in an environment that is arguably as favorable to incorporating HTAi into our decision-making process as anywhere. There are very tight links between our producers of information and our consumers of information, and there are very tight links in terms of the feedback loops that play through there. But at the same time, we're confronting what everybody in the room is confronting, which is we don't have any evidence that you don't have. The same sort of gap in good quality evidence to inform decisions is difficult for us as well. We probably have a little bit better idea on how things are working in practice, but that's inside our system and may or may not generalize. And I'm going to skip that slide and leave you to the next. So thank you very much.